going to have Dr. Michelle Monje, who's going to be speaking today about some of the cognitive challenges that people may have with head and neck cancer. So she is a professor of neurosurgery, of pediatrics, of pathology, psychology, and behavioral sciences. So she's like a true Renaissance woman. She does it all. She's particularly interested in the roles for neural precursor cell function and dysfunction in the origins of pediatric brain tumors, as well as the consequences of cancer treatment. So every year we've been getting requests for people who could provide some insight on things that people commonly call chemo brain, and we found the expert to do that for us this year. So come on up.
Well, it's so nice to be here, and actually, Todd, that's going to be a difficult talk to follow. We're really going to change gears here, but I just so appreciated everything that you said. It was really so I'm a professor of neurology, and I'm by training a basic neuroscientist. But for many, many years, and actually beginning with a patient I cared for who had previously been treated for head and neck cancer, I've been studying how cancer therapies influence the nervous system and why people, often, not always, but often experience cognitive symptoms in the long term. And so I'm going to give you a talk that includes a lot of details, but the details are less important than the message that we're beginning to understand this. And as we begin to understand it, we're beginning to develop potential therapies for the cognitive impairment that people can experience after cancer therapy. So just to sort of take a really big picture view and introduce you to some of the players in your brain, function of cognitive function of your nervous system really depends upon kind of a collaboration of a team of different brain cells that need to work together in order to function. And the sort of chief brain cell that we all think about are these electrically active neurons, and they have to communicate with each other, but they have to do that in sort of an organized and efficient way. And in order to be organized and efficient, they need the help of other kinds of cells called glial cells. And some of the glial cells that are really, really important for us to understand in order to understand cognitive symptoms after cancer therapy include cell types called astrocytes. They're called that because they look like stars. And they play really important roles in helping the neurons communicate with each other across connections called synapses. There are also a resident immune cell in the brain called a microglia. And microglia can do very, very helpful things and also can kind of change their behavior and be really harmful when there's a challenge, when there's a toxic or infectious challenge. And in the healthy nervous system, they also help to support communication between neurons. They help to sort of prune back extra connections so that it's all appropriately connected. And they help to support plasticity, sort of adaptive changes in the ways that the neurons communicate with each other. And then there are my favorite cell types now. Truly, I shouldn't have a favorite, just like with my children. I shouldn't have a favorite, but I kind of do. I really love these myelin-forming glial cells because myelin is very much like the insulation on a wire, right? It's like that rubber coating on a wire to help the electrical signal, travel quickly, travel efficiently. And these wonderful cells, put that kind of insulation on axons. And they don't just do it during development, but they sort of change and modify the insulation to sort of support the circuits that people use the most. So they're really plastic, they're really adaptable. And then in one part of the nervous system, we kind of finished making those neurons in most of the brain, during development. But there's one part of the nervous system that continues to make these electrically active neurons, and that's in a memory center called the hippocampus. And there's this ongoing generation of new neurons there, helps to support, we think, the formation of new memories. And what we've discovered over the last couple of decades, and I'm just showing you sort of, references to papers that have supported this, each of these different interactions between the neurons and the glial cells can be disrupted by cancer therapies. And so, what is the syndrome that I'm talking about? This so-called chemo brain or chemo fog. More formally, we call it cancer therapy-related cognitive impairment. It is a syndrome that affects a lot of patients who've survived cancer, both those who've experienced radiation that affects the cranium, so both focused on the brain or even focused near the brain that kind of scatters towards the brain, and those that have undergone chemotherapy of various sorts. And what this syndrome is characterized by is impairments in attention, in concentration, multitasking, kind of the speed with which information seems to flow, memory, and executive function. And so people find, particularly in the long term, and this severity can really vary from person to person, influenced by many factors, the exact kinds of chemotherapy drugs used, whether or not there was radiation therapy that did affect part of the brain. But it affects a lot of people, and it can result in difficulty remembering names, difficulty remembering, where you left your keys on the most mild end of the spectrum. But it can also be really debilitating. It can mean that it's harder for cancer survivors to go back to work or to go back to school, to engage in their life the way that they previously did. And the first patient that I saw suffering with this, I remember I was a medical student. This was a very long time ago. I won't say how, over 25 years ago. And it was a survivor of head and neck cancer. And back then, when head and neck cancers, particularly of the nasopharynx, were irradiated, it was difficult with the technology that existed then to protect this memory center in the brain, the hippocampus. And the degree of cognitive impairment really correlated with the extent to which that part of the brain was in the radiation field. But nobody at the time really understood anything about what was happening in the brain. And I was so moved by how affected this particular woman was, that I got to know as I was a student taking care of her, that I decided to sort of dedicate my graduate work, my PhD work, to trying to understand the influence of radiation on the hippocampus. And so for the long journey of about 25 years of doing research, we've looked at different kinds of cancer therapies that I'm going to tell you about now. So please forgive me for the nitty-gritty detail I might get into. Again, it's really about the overall message and the discoveries that are leading towards, hopefully, therapies to address this cognitive impairment. So as I mentioned, this affects a large proportion of people who survive cancer of various types. And what's been so mysterious is that, when we look at the brain, it often looks fine on MRI scans. It looks very normal. But people are really suffering from, these lasting cognitive symptoms. And so there's something more subtle going on. But with the brain, subtle is good. Subtle means that maybe, it's a process that is one of dysregulation, of dysfunction, not of destruction. So therefore, potentially therapeutically fixable. And what we've discovered over now many, many years is that that cell type from the group that I just introduced you to, at the center of the dysregulation, is that immune cell type, the microglia. And I'll tell you now a lot of nitty-gritty detail about how these microglia are messing up these important interactions in the nervous system that we need for the nervous system to develop and to function normally. So now going back, again, many, many years, a little over 20 years ago, what we found was that in this case, radiation causes really quite profound reactivity of these immune cells. It shifts them from doing their normal happy job in the brain to being really quite a problem. And they stay in that state. Once they sort of shift gears, they go from being helpful to being harmful. And the way that they disrupt the generation of new neurons, which I'm showing you here in green, and this is in a healthy hippocampus, in a hippocampus that has been exposed to radiation therapy, there is just this loss of those green newborn neurons that we need to help us make new memories. And we found that one of the ways that this happens is that those reactive immune cells make some signals. They make molecules. In this case, it's got this name IL-6. And that disrupts the function of the precursor cells that make those neurons. So that's important to know because it shows us one potential target for therapy. And as I grew up and developed my, became a baby professor and then became an older professor and, kind of went through that developmental trajectory and led my own laboratory. as we've studied different cancer therapies, those microglia and their reactivity and the way they mess things up kind of comes to the forefront again and again and again. I like to think about the cells like a family sitting around a dinner table, and, you have everybody is having a nice conversation, but, you have that really disruptive uncle who comes and and kind of disrupts the interactions that are happening. That's what these microglia are like, and they really kind of, throw a wrench into all of the interactions needed to function properly in the nervous system. So when we look at chemotherapy, and, I really thought we'd find a different mechanism of brain cell dysfunction with chemotherapy, which is so different from radiation. What we found was that, again, it was the microglia and the way that they disrupt neural cell interaction. So after a commonly used, we developed a mouse model of methotrexate-induced cognitive impairment. Methotrexate is a chemotherapy drug that is used very commonly in many different cancers, and it's an antimetabolite that's particularly associated with this cognitive dysfunction in the long term. And what we found was that methotrexate directly activates the microglia. But interestingly, because we had better techniques to look at this by this time, when we look at the whole brain, it's not all the microglia. It's just those in what we call the white matter, which is composed of myelinated axon tracts that become reactive. And then these microglia tell the astrocytes to become reactive. They send over signals that make the astrocytes reactive. So now neither the microglia nor the astrocytes are doing their normal job, and they're sort of acting in ways we would prefer that they didn't. And what they do is they mess up this myelin-forming process, and they hurt the myelin-forming cells. And without myelin, without that insulation, signals between parts of the brain are less efficient. We would expect information to be processed less well, to be processed less quickly, for attention and concentration to be disrupted. And we know that the microglia are central to this because we can target them in the laboratory. We can get rid of the reactive microglia, and everything gets better. The myelin comes back, and the mice have improved cognition. So it's not just, and this is a little bit of an esoteric point, but it's not just the myelin that we already have. It's the myelin that we need to make that gets messed up. And so there's plasticity of myelin. There's sort of these adaptive changes in the insulation in our brain that matters a lot to tuning our neural circuits. And I'll tell you that these reactive microglia also mess up that process. But what's important is that they mess up that process in a way, and these words don't matter, but the person at the bottom of the slide does. This is one of the trainees in my lab who did this work. It messes things up because it messes up an important signal between the neurons and the oligodendrocyte precursor cells that also might represent an important target for therapy. So the message that I really want to get across is that as we start to understand these interactions, potential ways to treat it become increasingly clear. So I'm going to tell you a story, I think just to convince you, I hope that we're kind of on the right track about the therapeutic direction to go, by showing that even when we get away from traditional cancer therapies, when we get away from radiation and chemotherapy, that immunotherapies do the same thing. And they do the same thing in the same way. And that really tells us that this immune dysregulation is important. And I probably put way too much detail into my slides, so please forgive me for that. But when we look at a kind of immunotherapy called CAR T-cell therapy, which has been in the news, it's been really helpful for people with refractory leukemias and lymphomas. It's showing, increasingly, exciting progress in solid tumors, including in brain tumors. But people who receive CAR T-cell therapy don't just have acute problems in their nervous system. And there certainly are some neurotoxicities that CAR T-cells can cause, when you first give the therapy. But in the long term, the early signs are that people are experiencing the same kind of chemo fog or brain fog, these cognitive symptoms that people have experienced with traditional chemotherapy and radiation. And so we wondered whether the CAR T-cell therapy, which is intrinsically immunological, might be triggering that reactivity of the immune cells as well. And just again, to show you the important thing on this slide, which are the people who do this work. This is, again, Anna Garrity, who worked on the chemotherapy-induced cognitive impairment story, and a wonderful PhD student named Lehigh Acosta Alvarez. And we looked at the way that CAR T-cell therapy might influence the brain using different mouse models. And we wanted to look at CAR T-cell therapy against tumors that are in the nervous system, against tumors that can go to the nervous system, like blood cancers, and that's a cancer type for which CAR T-cell therapy is FDA approved and commonly used, as well as for bone cancer, which is a cancer that doesn't go to the nervous system. And so there, the inflammation is completely outside of the nervous system. And what we found when we did, this experiment, and again, I don't want to focus too much on the details, but to just, show you that in each case, the tumor-treating CAR T-cell therapy, that invokes a tumor-clearing immune response, each impairs cognition in the ways that we can test it in mice, which are admittedly limited, but we can test attention and memory function in mice. And so, for example, this mouse, in a nice little chamber, gets to explore two objects made of Legos, and it really likes that. Mice like to explore new things. And then we take them out for a minute and put them in the box with a new thing, with a different Lego configuration. And a healthy, mouse will spend more time with the new Lego configuration because it wants to play with the new toy. But if it doesn't pay attention to and remember what it saw before, it'll spend equal time with both Lego toys. And so that's actually how we test, whether one of the ways in which we test whether a mouse has impairment in attention and memory. And the mice were impaired after treatment with CAR T cells in the lab for any of these kinds of cancers, including the cancer that's exclusively outside of the nervous system. And when we look at the immune response in the nervous system, when we look at the cerebrospinal fluid, that clear fluid that bathes the brain and gives us a sort of window into the kinds of signalings that's happening in the nervous system, we see that there's lots of inflammatory molecules being made within the nervous system, even if the immune reaction was outside of the nervous system. And along with that, we see this reactivity of microglia in the brain, again, in that same pattern we saw after chemotherapy, just in the white matter, just in the axon tracts. We see a loss of those myelin-forming cells, oligodendrocytes. And if you look, this is a very, very, very zoomed-in picture of what myelin looks like in cross-section. This sort of insulation, if you really think about the ways that neurons communicate with each other, it's through what's called an axon, which is like a wire, and that wire truly is insulated by the myelin, and you see that myelin surrounding these axons here. There are fewer myelinated axons after CAR T-cell therapy, just as there are fewer myelinated axons after traditional chemotherapies. And there's a failure to make new brain cells in the hippocampus, new neurons in the hippocampus. So this kind of pattern of, microglial reactivity to an immune stimulus or a toxic stimulus in the context of cancer therapy causes the similar pattern of cellular dysregulation in the brain that impairs cognition, but is potentially reversible. And just to show you that, if we target the microglia, again, in this context, after CAR T-cell therapy, if we get rid of those microglia using a medicine, then that rescues the myelin phenotype, it rescues those oligodendrocytes, and it rescues cognition in the mice. They can they can recognize the new Lego. They can find their way through a maze. And, again, it's limited the way that we can test this in mice, but it gives us a hint that it might be helpful in people. And so this immunotherapy-related cognitive impairment, which is, essentially chemofog, but without the chemo, again, has to do with inflammatory dysregulation of the way, and again, there's too many words on this slide, but the way that the way that cells need to communicate with each other in the nervous system to function. Now, I'm going to tell you a little side story, and this is just a nice point about the way that, science should work, that we study one process, and it can help us inform others. So when the pandemic began, understanding that cancer therapy-related cognitive impairment is chiefly an immunological disorder, it's chiefly, an inflammation-induced set of problems, I really worried that because of how immunogenic, how inflammatory COVID seemed to be, that we were going to suddenly have a lot of people who had what looked very much like chemo brain fog. And very quickly, this sort of COVID fog became clearly a major problem. So I thought, well, we might have some clues to this. We should study it. And science working, as it should, I reached out to a COVID expert in the heart of, the pandemic in spring of 2020, when all labs were shut down and everybody was on lockdown. And I cold called her and said, would you like to work with me? I have this idea as soon as we can get back into our lab. So, she developed a model of mild respiratory restricted COVID. So no infection in the brain in this mouse model. It's only in the respiratory system. It's a mild model. The mice they look great. They clear the virus in less than a week. They don't lose any weight. They eat well. They continue grooming. They're happy mice. And yet, when we look a couple months later, they have this microglial reactivity again, just in the white matter, and a loss of those oligodendrocytes and a loss of those myelinated axons. And when we compare the degree to which mice are losing myelinated axons after COVID or after methotrexate chemotherapy, it's pretty similar. So we think that there's really kind of this emerging common principle with shared features across different kinds of brain fog syndromes induced by radiation, induced by chemotherapy, induced by immunotherapy, induced by other peripheral immune challenges, including COVID, by which that immune challenge triggers this reactivity of this very sensitive, cell type. And that cell type then kind of wreaks havoc in the way that cells communicate with each other in the nervous system. And that results in really very debilitating symptoms for patients. And so as we understand this sort of emerging principle in brain fog syndromes, a number of potential therapeutic interventions are becoming clear, and we hope that this is something we can bring forward, for patients suffering from this after cancer therapies, but also for many people who suffer from cognitive symptoms after a range of immune challenges. So this is always a big team effort. These are all the people in my lab who contributed to that work I just summarized. Of course, our funding sources and really important other scientists that we've worked very closely with to understand it. Thanks so much for your attention and for going with me through that journey deep into, brain brain function detail. And I would love to take any questions if there are some.
So, in regards to the working therapies, actors to can refer to, are any of them actually being used?
It's in the testing phase. So, when we discover something in the lab, the first thing we need to do is to bring it to patients in a very controlled way to make sure that it's safe, to make sure that there aren't unexpected, toxicities of that therapy in that disease context. So right now we're in the phase of planning for phase 1 clinical trials. So early phase clinical trials. Not available yet, but trying to figure out which of the several options is the best one, the most helpful, and the one with the least side effects.
Yeah, so I have a question. I'm a stage 4 nasopharyngeal cancer. I like to call it conqueror. So anyway, I was curious, the brain fog, there's a combination of chemo and radiation that I have. How do you differentiate what are the impact potentially from chemo, or what are the impact from radiation? Because sometimes I do still, like earlier came in here, like my friend reminded me this incident, my couple died, I can't even remember anything. So there's stuff like that. It's too young for my age to not remember.
Yeah.
Right. So sometimes I couldn't really tell. And then the other thing, recently I also have some spinal scan that apparently between my C5 and C6, there's multi-disc degeneration, like whatever the myelin thing kind of maybe dry out or something. I was curious, given the intensive amount of radiation that I have and also radiation surgery, could that also impact my spine? Because there was some small metastasized to the nodules in addition to the neural nerves. And I was curious that the amount of radiation does also impact this area of the spinal health, like their central spines, like cervical spines.
Yeah, no, that's a great question. Great set of questions. So how do we differentiate the influence of radiation or chemotherapy? It's difficult because they cause very similar, effects on the brain, overlapping effects on the brain. We know that in patients who have chemotherapy with or without radiation that does, reach the nervous system, that the radiation has a very important effect. Radiation techniques have really improved over the years. And so, the radiation oncologists are able to keep radiation more confined, more exactly where they want it. And there's been a lot of effort. While we still don't have a intervention that I can say, what I can say is that this work did sort of inspire what's called hippocampal sparing radiation techniques. So whenever possible, knowing that the hippocampi, these memory centers, are so sensitive to radiation, the radiation oncologists have developed techniques now that really spare exposure of the hippocampi to radiation therapy. So every individual is different, and it depends on where the tumor is that is being targeted. So I can't comment on any particular person's radiation field consequences, whether radiation actually reaches either the hippocampus or the spine. But if radiation reaches the spine, and I can speak to the experience we have with children for whom we have to radiate the entire brain and spine to treat their, for example, medulloblastomas, which spread throughout the nervous system, there can be important effects not only on, the spinal cord, but also on the bony and, cartilaginous structures, that protects the spinal cord. So in the developing spine, that's really important. It can limit growth of the spine. In adults, it has less of a effect on, it's already grown, but there certainly can be effects on, the bone marrow that's in the vertebral bodies and potentially other effects. But it's hard to speak to whether for a nasopharyngeal carcinoma that the radiation field reached back towards the cord. And I will let the radiation oncologist answer the question. Thank you for the question.